Welcome back to The Deep Dive. Today, we're embarking on a pretty fascinating journey, really, into medical terminology, specifically the language we use to classify breast cancer.
And it's a big deal.
A huge deal. Our mission today is to unpack a clinical paper that isn't just suggesting, a few small tweaks.
No, it's calling for a complete paradigm shift.
A complete shift in how breast cancer is identified, classified, and ultimately managed. We're deep diving into this argument that the terminology we've used for a century is fundamentally flawed.
And potentially leading to some really dangerous misjudgments in the clinic. I mean, this is an issue of definition, and definitions drive treatment.
Right.
The entire system we use now relies on this historical ductal lobular dichotomy. But this research, and it was gathered over decades, proposes a total restructuring based on something much more precise.
Which is?
The tumor's exact physical site of origin within the breast tissue, where it actually starts.
Okay, so why is the current system so flawed? I mean, if you're a patient or a clinician, you hear ductal or lobular carcinoma all the time. It seems straightforward.
It seems straightforward, but it's misleading.
How so?
Well, the problem really goes back to history.
Yeah.
That dichotomy was established when doctors were only seeing tumors when they were, large, advanced.
Palpable, things you could feel.
Exactly. The original pathologists were making assumptions based on late-stage disease. But if you look at structurally similar organs that produce fluid,
Like the prostate.
like the prostate or the salivary glands, their cancers are already classified based on their anatomic site of origin. And that site correlates almost perfectly with long-term prognosis. Breast cancer has just lacked that essential precision.
That's a really helpful analogy. It's almost like judging a house fire just by the smoke damage,
Right.
without knowing if the fire started in the kitchen or the attic. The point of origin tells you so much about the danger.
Exactly. And the source material, which, by the way, relies on prospectively collected data stretching all the way back to 1977
Wow.
in places like Dalarna County, Sweden. It uses high-resolution imaging correlated with advanced 3D pathology. And it shows that breast cancers arise from 3 distinct sites.
And those sites lead to 3 major subgroups with very different outcomes.
Very different long-term clinical outcomes.
Yeah.
And the biggest shocker here, the thing that really stands out,
Yeah.
is the scale. Their data suggests that roughly 75% of all breast cancers are currently mislabeled.
Wait, say that again? 75%.
75% is a staggering number.
That is staggering. Okay, so let's unpack how that anatomical confusion even started. The paper points to early 20th century pathologists looking at, conventional 2D microscope slides.
Right.
What were they seeing and what were they missing?
They were missing depth. That's the simple answer. The widespread use of the descriptor ductal came about because pathologists at the time believed most cancers originated in the terminal duct. This view basically eliminated the concept of acinar carcinoma. But if you look at the actual anatomy, the smallest functional unit is the Terminal Ductal Lobular Unit, the TDLU,
And that includes the terminal duct.
and the lobular acini, which are these tiny grape-like sacs that actually produce milk.
So they were just lumping the grapes and the stem together and calling it all stem.
Precisely. In a conventional, very thin 2D slide, especially when that tissue is already distorted by the cancer itself, the entire TDLU structure can look elongated. It just looks like a simple duct,
So they looked at a flat image and labeled everything ductal.
ignoring the acinar origin completely.
Mm-hmm.
And that misidentification was monumental.
And this mix-up has a huge clinical consequence today, particularly around the term ductal carcinoma in situ, DCIS. Can you explain that core inconsistency?
The term DCIS is, right now, a single giant catch-all term.
Yeah.
It's applied to cancer cells accumulating in the major lactiferous ducts, the big tubes leading out, and also to cancer cells accumulating in those much smaller TDLUs. The paper argues very forcefully that these are profoundly different pathological processes.
With profoundly different outcomes.
Exactly. Lumping them together under one name, DCIS, just obscures their true nature.
So if this confusion has existed for a century, how did these researchers finally resolve it? What was the methodology that let them see the true site of origin?
They revived and modified a much older, more intricate technique. They used large format, subgross, 3-dimensional histopathologic images.
So not thin slices.
Not thin slices. They examined thick, often whole mount sections, which lets them see the full, undistorted 3D architecture of the cancer's growth pattern. And this method visually confirms that approximately 3 out of 4 breast cancers, 75%.
There's that number again.
There's that number again. It confirms they actually originate in those little Acinar sacs within the TDLU.
So now we have confirmation that the majority of breast cancers are mislabeled as ductal when they're really acinar. So based on this 3D mapping and decades of patient outcomes, they propose 3 new anatomically defined subgroups.
Modeled really after the clarity you see in prostate cancer classification. We move away from the misleading ductal lobular split to a system based strictly on anatomical origin.
Okay, let's go through them. The first, and by far the most common type, at about 75% frequency,
Is Acinar Adenocarcinoma of the breast, or AAB.
this is the cancer originating from those terminal ductal lobular units, the TDLU type.
Exactly. Then second, accounting for about 20% of cases, is Ductal Adenocarcinoma of the breast, or DAB.
And crucially, this is the one originating specifically from the large major lactiferous ducts, the major duct type.
That's the one. And finally, the smallest group, only about 5 to 8%, is the really odd one out. Breast cancer of mesenchymal origin, or BCMO.
And this one arises from the mesenchyme, the structural framework of the breast, through a complex process.
A process called mesenchymal epithelial transition, or MET.
So the dramatic implication here is that the old system is broken because it failed to define that huge AAB type correctly.
It failed completely. If we adopt this new system, we are instantly isolating the majority of cancers based on their actual origin.
Okay, let's focus then on that majority AAB, the 75% type. This is where the imaging markers really become the clincher because the mammogram, you're saying, doesn't lie. It reflects the true pathology.
It tells the story perfectly.
How do these images tell the story of AAB?
They tell it because the in situ phase of AAB is visually distinct. The calcifications we see on a mammogram correspond directly to what the low-grade cancer cells are doing in those small Acinar sacs.
So for the lowest grade, grade 1 in situ AAB, what does the mammogram show?
It presents as multiple clusters of powdery calcifications.
Powdery. What does that actually mean visually for the pathology?
It means the cancer cells are producing a lot of fluid and cellular debris, and they form these tiny semoma, body-like calcifications that are just floating freely inside the Acinar.
So they literally look like fine powder or sugar dust on the image.
Exactly like that.
And if the cancer is a bit more aggressive, say grade 2.
For grade 2 in situ AB, the pattern shifts. It becomes a cluster of crushed, stone-like or pleomorphic calcifications.
Crushed stone.
And this visually corresponds to areas of necrosis cell death happening inside those little sacs. When the tissue dies off, it forms those larger, amorphous, crushed stone shapes.
So the texture of the calcium is a direct visual clue to the grade and behavior of the cells.
A direct clue.
Now, for the optimistic news, based on decades of follow-up for this very common subtype, what's the prognostic insight for AAB?
The data is overwhelmingly positive for AAB. They found that unifocal invasive AABs, if they're smaller than 15 millimeters and don't have a high-grade component, were rarely fatal at long-term follow-up.
So early detection here makes a huge difference.
A dramatic difference.
Which really begs the question, if we adopt this precise classification, what is the biggest immediate relief we can offer patients?
It's the relief from unnecessary and potentially harmful overtreatment.
Right.
If 3 out of 4 breast cancers are this AAB type and the imaging tells us it's low-grade and small, we can potentially spare these patients the toxicity of chemo, radiation, or excessive surgery that the current flawed system might demand.
Precision classification means precision de-escalation of therapy.
Where appropriate, absolutely.
Okay, that's the good news story. Now we have to talk about the aggressive flip side. Ductal adenocarcinoma of the breast, DAB, the 20% type.
Originating from the major lactiferous ducts.
And this is where the current term DCIS becomes, as the source material argues, dangerously misleading.
This is the core management failure. It really is.
Yeah.
DAB is a high-grade, often highly malignant disease, and when it's found, it frequently involves something called neoductgenesis.
Which means new duct formation. So it's not just sitting in the duct.
It's not just sitting there.
It's aggressively building new duct-like structures.
Exactly. It's an invasive carcinoma that is forming multiple branching structures throughout the breast lobular system. And to call this potentially fatal, high-grade, expansive disease in situ,
Which means in place.
which suggests that it's harmlessly confined in place, is a dangerous failure of language. It completely masks its true biological threat.
So what's the unmistakable imaging biomarker for this aggressive DIB subtype? We had powdery and crushed stone for AB. What does DIB look like?
The classic finding is numerous fragmented casting type calcifications.
Testing type.
Yes, so if the powdery ones looks like sugar, these look like long, fine, linear branching shards, or maybe like the branching roots of a tree following the ductal system. They have a diffuse lobar distribution.
And when you look at prognosis, the difference between the 75% AAB and this 20% DAB is massive.
It's vastly different. If you have a small invasive AAB, but it's associated with these casting-type calcifications from DAB, the fatality rates soar. In one study, the 24-year cumulative survival for small AAB alone was over 90%. But if that same size AAB was found with DAB components, survival plummeted to around 62%.
Wow.
The severity is driven entirely by that high-grade DAD component.
And this raises a critical point about management, specifically the biomarkers. If DAB is the killer, are we even checking its biomarkers correctly?
We are frequently not. This is a massive issue. Routine biomarkers like HEA2 status are often not determined from the cancer cells within those major ducts.
Why not?
Because clinicians and pathologists assume it's just benign in situ DCIS. It's categorized as non-invasive, so they just skip the analysis.
And why is missing a HER2 result such a management failure? What does that mean for the listener?
It means we miss the opportunity for targeted therapy. High-grade GAB cells are frequently found to be HER2 positive. If you miss that result, you are failing to offer the patient highly effective targeted drugs that could significantly improve their prognosis.
So the current classification system is allowing a highly treatable but highly aggressive cancer to be mistakenly ignored as harmless.
That is the bottom line.
That is a direct life or death consequence of flawed terminology. Let's move to the final, rarest type, BCMO, the breast cancer of mesenchymal origin. This is the subtype that presents a clinical paradox.
It really does. BCMO at 5 to 8% is tricky from the very start. Clinically, it's difficult to find early. It often presents just vaguely as a palpable thickening, not a clear lump.
And on a mammogram.
Notoriously hard to detect. It usually only shows up as subtle architectural distortion. It often has a large amount of fibrous connective tissue, which makes the lesion very hard to characterize.
So it's extensive, hard to detect, and has an alarmingly poor long-term outcome, a 40% fatality rate, according to the source material.
A 40% fatality rate.
But the cellular markers, the things doctors often rely on, they tell a completely different story, don't they?
They tell a completely contradictory story. This is the paradox that truly validates the need for this classification shift. Most BCMO cases are estrogen and progesterone receptor positive, ERPR positive, they're HER2 negative. And their proliferation index, Chi67, is extremely low.
Often 1 to 5%.
Right. And for anyone unfamiliar, those values, ER positive, HER2 negative, low Chi67, that screams favorable outcome in modern oncology.
It suggests a slow-growing, hormonally responsive cancer.
Exactly. These are the values we conventionally use to define a low-risk breast cancer that might not even need chemotherapy.
Yet, BCMO has a 40% fatality rate.
And that disparity, a low-risk profile paired with a high fatality outcome, it just highlights the absolute danger of classifying cancer based only on cellular markers, divorced from its anatomical origin and its imaging features.
The site of origin is overriding the cellular marker.
It is the defining prognostic factor.
So we've cataloged the three types. We have AAB, 75% generally favorable. We have DAB, 20% highly aggressive and a management failure. And BCMO, 5% paradoxical, poor outcome, masked by low-risk markers. What's the ultimate takeaway for clinicians and patients? How does this proposed new classification fundamentally change the workflow?
The clinical consequences are stark. The current terminology leads to two major failures. First, the potential overtreatment of favorable AAB cases, subjecting patients to unnecessary toxicity.
And second,
the dangerous undertreatment of the aggressive DAB and BCMO cases because their true severity is masked by the misnomer in situ or these misleading low-risk cellular markers.
So the power of this paper really rests on linking these three different fields: imaging, anatomy, and prognosis.
It connects the dots.
It argues that mammographic tumor features, those distinct calcifications, are reliable visual predictors of long-term outcome because they reliably indicate the true site of origin.
It connects the dots visually, anatomically, and prognostically. And this strong evidence really supports a fundamental shift in the entire management workflow. It challenges established systems like the TNM staging, which currently doesn't capture the true biological danger implied by the tumor's architectural origin.
If we classify by where it starts, we know where it's going.
That's the idea.
And that leads us to our final provocative thought for you to explore. Given that the long-term outcome for the aggressive DAB and the paradoxical BCMO subtypes has unfortunately not improved significantly in recent decades, despite all our advances in treatment, how critical is the shift toward using advanced imaging modalities like automated breast ultrasound, tomosynthesis, and artificial intelligence to find these diffusely infiltrating, highly aggressive cancers even earlier than current standard mammography allows? If early detection is the key for 80, what technology do we need to bring that same prognostic success to the other, more elusive 25%?